The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone and welcome. Thank you for joining us for the Nihik University program today on Meaningful Use Stage 2. This is Kate Berry, CEO of National eHealth Collaborative, or NEHIC. NEHIC is a public-private partnership with a mission to advance nationwide health information exchange to improve health and health care, including providing education on health IT. Today we are pleased to welcome our distinguished speaker, Robert Anthony from the Centers for Medicare and Medicaid Services. I'll introduce him in just a minute. To highlight a few of our upcoming NEHIC University programs. We offer a wide variety of education programs, including Spotlight Learning Series on Health Information Exchange, Consumer Engagement, and the Beacon Communities. We do programs on careers in health IT, as well as many of the ONC initiatives. And we have a series on trends in health. We have a series of webinars coming up providing in-depth case studies of the Beacon communities. On Wednesday, April 11th, we're going to have a program featuring the Western New York and Southeast Michigan Beacons. On Thursday, May 24th, we'll have a program on the Utah and San Diego Beacon communities. Next slide, please. Our Spotlight Learning series on consumer engagement in health IT will include discussions of the opportunities and challenges of leveraging health IT to engage consumers and case studies of consumer engagement best practices. On Monday, April 23rd, NEHIC will have a program entitled Making Collaborative Care Work, featuring Dr. Charles Kennedy, Director of ACO Initiatives at Aetna, and Dr. Ralph Kortman, CEO of Centra Health. These speakers are going to present a case study on the results achieved at the Kettering Health System in Dayton, Ohio. On Tuesday, April 24th, we'll have a webinar on improving patient-provider communications, results to date from the Open Notes project. Joining us for that program will be Dr. Tom Delbanco, lead investigator for the Open Notes project and professor of general medicine and primary care at Harvard Medical School, Dr. Danny Sands, who is a co-chair and founder of the Society for Participatory Medicine, and patient advocate Dave DeBronkart, probably more widely known as ePatient Dave. Next slide, please. You can download and print the slides from today's program at the URL on your screen. And if you're interested in further dialogue and interaction, please join our online community at HIE Leadership and Sustainability. Next slide, please. During the program today, please submit your questions as they come to mind by entering them into the Q&A window at the right side of your screen. And now I'm very pleased to introduce our speaker, Robert Anthony. Rob is a health insurance specialist in the Office of eHealth Standards and Services at the Centers for Medicare and Medicaid Services. He works primarily on meaningful use policy for the Medicare and Medicaid EHR Incentives Program. So after the presentation, we'll open it up for Q&A. So once again, please do enter your questions as they come to mind. And now we're going to turn the presentation over to Robert.
Thank you, Kate, and thank you to the National eHealth Collaborative for sponsoring this webinar. What we're going to do today is we're going to do a brief overview of the Stage 2 Notice of Proposed Rulemaking. I'm going to talk about some of the different areas that are here and go over a very high-level overview. This is going to be the very fast version, Cliff Notes version, so that you will have some opportunity to ask or answer some questions or ask some questions, and I'll have an opportunity to answer at the end. So my name is Rob Anthony. I'm with the Office of eHealth Standards and Services, and we are the office within CMS that really is sort of the steward of the program within the Centers for Medicare and Medicaid Services. I just want to remind everybody that this is a proposed rule. Everything is now out and on and published in the Federal Register. You can see these links here under the CMS rule. That link will take you to where that is in the Public Register or the Federal Register. There's also a companion rule, which is published by the Office of the National Coordinator of Health IT, that deals with the standards and certification capabilities of electronic health records technology. that is used in order to achieve stage 2. So please, you should look at both of these rules in tandem. They sort of inform each other about how things are done. So as I said, the NPRM is published now. It was published on March 7th. Comments can be made through May 7th. We encourage people to make their comments through www.regulations.gov electronically. It does make it a little easier for us to sort them. So what you'll see in the proposed rule is some minor changes to stage 1, sort of retroactive. We're going to go over what some of those are at a high level. Obviously, proposal for an outline of what the stage 2 meaningful use objectives will be. There are new clinical quality measures that are proposed here, as well as new reporting mechanisms for those clinical quality measures. There is an outline of how the appeals process will work for the EHR incentive programs, and then there are details on the Medicare payment adjustments that are included or were included and required by Congress as part of the incentive program. There are also some minor Medicaid program changes, and we'll review those at a very top level a little later on. One of the things that we do propose in this is a slight delay in the onset of stage 2. This probably isn't a surprise to those of you who've been following this closely. The Secretary of Health and Human Services, Kathleen Sebelius, had announced our intention to propose this delay for stage 2. And as you can see, the shaded area of the box there, if you began your first year of meaningful use in 2011, and this is your first year of meaningful use, it would not be a first year of Medicaid adopt, implement, upgrade. It's actually your first year of meaningful use. You will essentially not have to meet stage 2 requirements starting in 2013. This is how it was originally proposed in the stage 1 final extra year at the stage 1 requirement. And this was done so that we could give vendors some more time to develop products for stage 2 and get them out into the marketplace, and of course so that providers had some time to implement those products into their workflow. One thing that I do want to point out about this, because it does come up fairly often when we talk about stage 2, is that no matter when you begin meaningful use, you are always going to begin meaningful use at stage 1. So if you begin in 2011, you will start with 90 days of stage 1 and move on to a year of stage 1. If you began in 2016, you would start with 90 days of stage 1 and then a year of stage 1 before progressing to stage 2. So no matter when you start, you are always going to start with stage 1 meaningful use. This is sort of the escalator concept that you move up on. This is the overall structure of stage 2. On the left, you'll see the way that stage 1 was structured for eligible professionals. You can see we have the core menu split that everybody is familiar with 15 core and 5 of 10 menu. Hospitals have 14 core, 5 of 10 menu. We retain that core menu structure for stage 2. So as we go through and we look at these, you'll see a similarity there. We did try to keep the total number of objectives relatively similar. One of the ways that we did that, as you'll see, and I'll go through some of this, is that we collapsed some objectives into each other. So there are objectives that accomplish multiple things that there were different objectives for or separate objectives for in stage 1. There are some places where we have proposed getting rid of objectives altogether. So you'll see that eligible professionals will have 17 core objectives and 3 they would have to select, and hospitals 16 with 2 of 4 menu objectives. I'm going to go through very quickly through both the core and menu objectives. I'll spend most time on the eligible professional side. A lot of these are echoed. You'll see when we go and look at the eligible hospital core objectives. One thing that I want to point out before we get started is that we have tried to bold face in these different objectives where things have changed from stage 1 for easy reference. So for example, you'll see that with recording demographics, recording vital signs, we bolded 80%. The reason that's bold-faced is because in stage 1 it was 50%. So you'll see, for quick reference, that's what we've done as we go through these. So as we go through, you'll see computerized provider order entry. We have raised or are proposing to raise that threshold from its current to 60%. Currently in stage 1, it is medication orders only. We are adding or proposing to add laboratory and radiology orders to that. E-prescribing, we are proposing raising the threshold. This 50% is actually incorrect. my apologies, I should have corrected it from the last time we did this. We are actually proposing a threshold of 65% for this. The recording objectives, 3, 4, and 5, which are demographics, vital signs, and smoking status, we are raising from 50 to 80%. Those folks who are familiar with the Stage 1 core objectives will notice that missing from this list, usually right around this place, are objectives for maintaining a problem list, maintaining a medication list, and maintaining an active medication list. We aren't proposing to get rid of those, but we are proposing to collapse them into an objective that I will point out later. So those are not separate objectives, but bundled with another objective. Number 6 shows another example of where we bundle. We had a clinical decision support requirement or objective in Stage 1. We are now proposing for Stage 2 implementing 5 clinical decision support interventions that are based on clinical quality measures that you report. We did not have that clinical quality measure requirement in Stage 1. But it is what we are proposing for Stage 2. We do recognize that there may not be clinical quality measures that apply to all eligible professionals. So in the case that you don't have clinical quality measures on which you report, or you don't have enough on which you report to base your clinical decision support interventions, you can base them on high priority clinical conditions for you. We did take a separate objective from Stage 1 and make it a second measure for this. And that is implementing drug-drug and drug allergy interaction checks. Partly we did this because we were looking for a way to kind of consolidate that clinical decision rulemaking. Partially we did it because there is an incredible confusion about drug-drug and drug allergy interaction checks and whether it can be used as to satisfy your clinical decision support rule in Stage 1. That is actually the most frequently asked question on our website. The answer, of course, is no, and so we put them together as 2 separate measures of the same objective here. Incorporate lab results are moving from the menu to the core. We did this with a number of menu to core. We signaled that we would do it in the Stage 1 final rule. This was the concept of deferral in Stage 1 for menu objectives. You could defer 5 of those, and you were deferring them until Stage 2 when they would become required. And we moved virtually all of those to the core for Stage 2. You will see a couple of areas where we didn't. I'll draw attention to those. Generating patient lists and patient reminders, 8 and 9, were moved from menu to core. We are moving away with 10 from the notion of providing an electronic copy of health information to patients when they request it. On the hospital side, it's the discharge instructions. We're moving to the idea of online access. You may remember that in Stage 1, there is online access through a PHR or a portal. We are moving towards online access where a patient can view, download, or transmit their health information from an online, whether it is a portal or whatever it may happen to be. So that would be available for 50% of patients through that electronic portal. The portal technology itself would be part of certified EHR technology, so we often get asked the question whether that would be something you'd have to go out and purchase separately, and in some ways that is a separate module for certified EHR, but it is going to be something that is actually certified. I also want to draw attention, there is a second measure to this. There are a couple of places where you're going to see this in Stage 2 where we have added what is really a new component for Stage 2 measurement. As you will recall, in Stage 1 there was really nothing that a patient could do or couldn't do that would prevent a provider from meeting meaningful use and receiving an incentive payment. It really was about providers taking actions. We are introducing a new concept here where we're actually putting the burden of responsibility for certain patient actions on a provider, and in this case it is for providing online access that actually 10% of patients are accessing that information online. It's a fairly low threshold, but we do believe that providers, as we discuss in the rule, are in a unique position to encourage patients to actually use that technology and take an active part in their health care. We did move from providing office visit summaries from a 3-day window to a 24-hour window. Providing education resources, moved from menu to core. Number 13 is a new objective that was that we actually proposed for the core instead of the menu. Most of the new objectives actually did end up in the menu, but this one we thought was important and we moved to core. It again is part of that concept of patients taking an action for meaningful use, and in this case it's that more than 10% of patients send secure messages to their EP using the technology that certified EHRs will have. So this secure messaging technology, whether it is a secure email or secure messaging through the online portal where you will put health information, will actually be part of certified EHR. And again, the idea is to actually get patients to send these messages. Medication reconciliation moves from menu to core with a higher threshold. Number 15 represents a really the robust step in information exchange that we are proposing for stage 2. So there was a providing a summary of care document in stage 1. There was also an objective for exchange of key clinical information. We are actually proposing to get rid of the key clinical information, and we're really looking, instead of random cases of exchanging key clinical information, we are focusing on exchange that really makes sense within the continuity of care. So we're putting the emphasis on providing summary of care documents for more than 65% of transitions of care. Some of you may remember that in stage 1, the only real requirement for transitions of care were to include diagnostic test results, problem list, medication allergy list. There's a host of new documents or new fields that we are proposing to include in summary of care in stage 2. It's a fairly lengthy list, and I would encourage people to take a look at the proposed rule to see what that list actually is. But it is a very robust amount of information. A lot of it is demographic information that is already there, but there are other things such as provider contact information, continuity of care plans if they exist, so on and so forth. So please take a look at that. The other aspect, or the other measure of this objective, is that 10% of those transitions of care, summary of care documents, have to be sent electronically. And there are some caveats around that. We do specify some acceptable standards for transport. And we also specify that when sending these 10% electronically, they have to be sent to a different provider, and that is a provider who does not have an organizational affiliation with you. And it has to be sent to somebody who has a different EHR. And this is not a different instance or a different license of an EHR. It's actually somebody who has a separate EHR entirely. So in other words, if I wanted to electronically send a summary of care document to Dr. Smith, and I am on, say, Epic 9.5, Dr. Smith would need to be on a completely different EHR like Meditech. So something that is a completely different vendor. Number 16, we are moving away from the testing of sending immunization data to successful ongoing transmission of immunization data. You will see that we left syndromic surveillance in the menu. We did that for EPs simply because there aren't enough syndromic surveillance databases right now to really require that as a core objective for EPs. As that matures, we'll revisit it. But certainly for hospitals, there are access to syndromic surveillance databases, and we've moved all of those public health reporting objectives to the core. And then finally, 17 is our privacy and security objective, which remains unchanged from stage 2. These are the menu objectives. Again, EPs have to report on 3 of 5. I do want to draw attention to a slight change that we made in menu objectives, or we're proposing in menu objectives for stage 2. You remember in stage 1 you had a deferral concept, so you would defer. This turned out to be a very confusing concept for a lot of folks to grasp. So we have actually moved to a straight choice. So there are 5 menu objectives. You have to select 3. We're also eliminated a little bit of a loophole in which a provider could have essentially chosen in stage 1 a menu objective and then excluded themselves from it even though there were other menu objectives that they could have reported on. For stage 2, if you are excluding from a menu objective, then you are also attesting that you would exclude from all of the others. Exclusions still don't prevent you from meeting meaningful use, but in other words, if you meet the exclusion for 2 of these menu objectives, then you have to report on the other 3. If you meet the exclusion for 3 of the menu objectives, then you would have to report on the remaining 2, and so on. One of the new ones here is number 1, incorporating imaging results. More than 40% of imaging results are accessible through certified EHR technology. I want to put the emphasis on accessible. It is fairly open. We welcome comments on this. The imaging results don't have to be part of certified EHR technology. They don't have to be loaded into certified EHR technology. They just have to be accessible. So a direct link that would take somebody into a different imaging system, for example, would be acceptable for meeting that measure. Recording family health history for more than 20% of patients. We mentioned syndromic surveillance staying in the menu. We are adding 2 other public health options for EPs. One is successful ongoing transmission of cancer case information, and one is successful ongoing transmission of data to a specialized registry. We do know that there are some specialists who contribute information to registries specific to what they do. I won't go through all of the hospital objectives because they are substantially very similar to what you're going to see in the EP, or what we've just gone through. So you see your recording demographics. It's implementing 5 clinical decision support that are based on clinical quality measures. Obviously, all hospitals should be able to base them on clinical quality measures because there is a standard set that they all report on. The online access is included here as well. One of the new areas is for EMAR, electronic medication administration recording, and that is to make sure that medication is tracked throughout the hospital. We are only putting a percentage threshold of 10% on those medication orders at this time. Education resources in MedRec are brought over from the menu. Again, you see here the summary of care and the transitions of care, 10% sent electronically, and again, it is to providers outside or who don't have an organizational affiliation and who have a different EHR. 13, 14, and 15 are the public health submissions, and 16 is privacy and security, unchanged from stage 1. You'll see that the menu objectives for hospitals are substantially very similar to what we went through for EPs. Again, hospitals will do 2 out of 4 here. We did leave the recording indications of advanced directives in the menu objective set for hospitals, even though it was also in the menu objective set for EPs. And the rationale behind this was simply that we've had some conflicting back and forth with different states about what really legally can be considered an actionable advance directive. And until we really see some resolution or consensus about that, we feel that it needs to stay as a menu option. Incorporating imaging results or having them accessible through certified EHR, recording family health history. And then number 4, a new one, is e-prescribing for more than 10% of discharge prescriptions for hospitals. We are proposing some changes to stage 1. These are retroactive. Most of them are optional in 2013, but would be required in 2014. And this is to align with the way that certification is going to work. There's not going to be a stage 1, stage 2 certification for products. There's a 2011 and a 2014 certification. And once you upgrade to a 2014 certification, those EHRs are going to have the ability to do both stage 1 and stage 2. So obviously some of these won't change with your current EHR, and some vendors may choose not to update the way they do their reporting on this. So we didn't feel we could require it, but it is an option for folks in 2013. One change is to CPOE. Right now the denominator is unique patients with at least 1 medication in their medication list. The feedback we've received is that this turns out to be an incredibly difficult concept for folks to grasp. A lot of people weren't sure whether it was a medication that was just ordered by the EP who is reporting or who is attesting. It's not. It's any medication that's ordered by anyone in the med list. Some folks thought it was a medication that was ordered within the reporting period. It isn't. It's not time limited. But because it generated a lot of confusion, and because it actually generated a lot of confusion even with vendors, we are proposing to change it to a fairly straightforward denominator of the number of orders during the EHR reporting period, and then the numerator would be the number of orders that are placed using CPOE. Vital signs, we're doing a couple of different things here. One is we had put age limits at age 2 for blood pressure and height and weight. We're proposing a split of age 3 for blood pressure and no age limit on height and weight. We're also doing a similar split with exclusions. Right now the exclusion for vital signs is if all 3 elements are not relevant to your scope of practice, you can claim an exclusion, but we've since gotten a lot of feedback from providers, especially specialists, that there may be some that would record blood pressure but not height and weight, or vice versa. So essentially there will be an exclusion from recording blood pressure or an exclusion from recording height weight. Obviously there can still be an exclusion for both of those things. That again will be optional in 2013, but it would be required in 2014. As I said, we are proposing to eliminate the test of electronic transmission of key clinical information. That also turned out to be an incredibly difficult concept for folks. They weren't sure what they had to actually transmit. They weren't sure how they were supposed to transmit it. We did release some sub-regulatory guidance in the form of FAQs, but it really did engender a lot of confusion with folks. Those are FAQs that do continue to be accessed fairly frequently, and all of this really for an objective that is a test. You could fail the test, you could be successful with the test. Either one of those were enough to meet the objective. So we are proposing to remove the objective entirely in 2013. We are also proposing to electronic access to health information and replacing them with an objective to view online, download, and transmit health information. This is really to align with the Stage 2 objective, which would provide online access. We really, with 2014 being a single certification, there was no sense in duplicating multiple ways of doing this. If it was already going to be included in the EHR, then we just figured that we would have people use that capability. However, we aren't proposing in Stage 1 the extra measure of having 10% of patients access it. That is just a Stage 2 proposal. And then finally, a very small change for public health objectives. This is the immunizations, syndromic surveillance, and reportable labs for hospitals. We're adding the except where prohibited to all 3 of those language. That would be effective in 2013, and this is really because we've just had some feedback that there are some local areas where reporting certain data is prohibited, and it was never our intention to require this of folks and them not be able to meet it because of local regulations or laws. So we are adding this language. Very briefly on CQMs, right now you'll see on the left we have for EPs the 3 core or 3 alternate core CQMs plus 3 menu out of a selection of 38 for a total of 6 or possibly 9 if you have alternate cores. Hospitals have 15 total CQMs. We're proposing a number of things with clinical quality measures in this NPRM. One of them is a structure where there would be 12 clinical quality measures reported. Out of those 12, at least 1 from each of 6 domains that we propose. These 6 domains align with the Health and Human Services National Quality Strategy. There's more information about this in the proposed rule, so I suggest everybody take a look at that. The other option is that we would have a core of 11 that all EPs would report on, and then everybody would select 1 menu CQM from a variety of them. So we're seeking public comment about which way people think is the best to do it. There's also a number of different possibilities for alignment of things, and that's really been the goal with CQMs for this new 2014 proposal is to get it to the point where people are reporting the same thing across programs and they're not having to report multiple times to CMS about multiple programs. So one option is for people to utilize the PQRS system. That's the Physician Quality and Reporting System. If you're reporting through that anyways, you would report through that, and you would essentially be deemed for having reported your CQMs for the EHR incentive programs. There's a similar proposal for ACOs. If you were reporting through your CQMs through ACOs, then you would essentially be deemed for EHR incentive. A proposal of a group reporting option that would allow you to, we'll cover what some of those proposals are, but they essentially allow you to bundle the CQM information and do one report for an entire group that would stand for all of the EPs. So again, we've got a few different structures and a few different reporting methods that we're seeking comments on. I encourage everybody to take a look at that in the NPRM. Eligible hospitals, the proposal is to move to 24 CQMs with at least one coming from each of those domains that I previously mentioned. The one thing that I like to call attention to here is that this isn't a stage 1, stage 2 thing for CQMs the way that it is for the meaningful use objectives. It is the way that you currently report CQMs, and then in 2014 everybody would move to the new way of reporting CQMs. Whether you're in stage 1 or stage 2, you would fall under this 12 CQMs, or you could report through other programs in a line, or you could do group reporting. So similar to the way that the certification is going to work, the clinical quality measures would start being the same for everybody in 2014. There are some group reporting options. I want to stress that this is for Medicare only. Medicaid, the states will decide what different options that they are going to support. One option, as I said, is if you are number 2 in an ACO, a Medicare Shared Savings Program, and you're already reporting clinical quality measures through those, you'll essentially be deemed. EPs that are reporting through group reporting of the PQRS GPRO option, if you don't know what that is, you can go to our website and look at it, but essentially it's just the reporting mechanism electronically that we're using right now for people in groups to be able to upload for the Physician Quality and Reporting or Physician Quality Reporting System. If you want to take advantage of that as a group, you can, and you'll report once and be deemed. And then finally, if you want to do group reporting and you don't fall under either of those, then any two or more EPs that are related under a single tax identification number, presumably the group, would be able to report as a group, and you would submit the way that EPs normally submit, whether it's the 12 CQMs that are one from each domain or the 11 CQMs plus one menu. You'll be able to report it that way as well, and there'll be a reporting option for it. There are some Medicaid changes here. One of them is, one of the changes is the expansion of the definition of a Medicaid patient encounter. This basically allows a little bit more flexibility for meeting the patient volume. There are a number of things that sort of fit into this, and it gets weedy in a couple of places. So if you are curious as to how we are looking to or proposing to expand that definition of a patient encounter, I encourage you to take a look at the section in the NPRM. It is actually a fairly small section of the Medicaid area, and it'll tell you all of the ways that we're talking about doing it. The other thing we're talking about or proposing doing is enabling the participation of 12 children's hospitals that were inadvertently excluded from participating in EHR incentive programs. It probably doesn't affect most people, but for these 12 children's hospitals, the way that CMS recognizes a hospital is through its CMS certification number, its CCN. That's how we know an organization is a hospital. But these children's hospitals never accept Medicare, as you might expect. So they don't have a CCN, and they were inadvertently excluded, and we're essentially proposing a system by which they would get fake CCNs or stand-in numbers that would allow them to participate. One of the things that this NPRM does talk about are the payment adjustments. The payment adjustments are required by HITECH Act. Congress put them in. We don't have any latitude about employing them or not, but we do have latitude about the ways in which we look at these. We are essentially proposing a look-back period because the way that the law reads is that the payment adjustments have to begin to take effect in 2015. So that means January 1st, 2015 for EPs, and it means October 1st, 2014. That's the beginning of the 2015 fiscal year for hospitals. EPs work on calendar, hospitals work on fiscal. So we're essentially saying that we're going to look back at your closest EHR reporting period and see if that makes you a meaningful user. So in 2015, if you have been demonstrating meaningful use in 11 or 12, we're going to look back to see your full year EHR reporting period in 2013 to see if you were a meaningful user, and if you were, then you won't be assessed a payment adjustment, and this will continue along this way for 16, 17, 18, or you'll see we keep looking back 2 years. And essentially this is because we have to look back, because we have to do it in 2015. We need to look back in 2014, and if you are doing a full year of reporting period, you won't have submitted anything for 2014 by then. So we need to look back at the last complete period we have. Similarly, if you demonstrated meaningful use for the first time in 2013, we'll just look back to see if you have a 90-day reporting period in 2013. It could be any 90-day reporting period. If you haven't demonstrated meaningful use until 2014, that's fine. It's not a problem. We're just going to look at for a 90-day reporting period in 2014. But because we need some time to look for that period, we need to process your attestation, and then we need to process it through the payment adjustment system. We're essentially cutting off a deadline in 2014 by which you would have to submit your attestation as a meaningful user to avoid the 2015 payment adjustments. And you can see that those deadlines are put down here. It's essentially 90 days before the end of the calendar or fiscal year. So October 1, 2014 for EPs, for hospitals, July 1, 2014. We are also proposing some hardship exceptions here. These are they're possible in or made possible in the HITECH Act, and we are proposing these on an application basis. One of them is based on insufficient internet access. Essentially, if you are in a low broadband area, there are a lot of these stage 2 objectives, especially that depend on information exchange. If you're in a low broadband area, that may be a particular hardship for you. We're going to look back 2 years prior to that payment adjustment year, so in 2013, we'll look back to see if you are in an insufficient internet access area. We also are proposing some hardship exemptions for newly practicing providers, whether that's EPs or hospitals. We didn't want people who are right out of the gate, EPs, for example, who are fresh out of residency, and they don't have a look-back period. They don't have anything for us to look back at and say, you know, I've been a meaningful user. We wanted to give them sort of a grace period. So it's time limited for EPs. You get basically 2 years to establish yourself as a meaningful user. Hospitals, they get at least 1 full year cost reporting period, and for critical access hospitals, it's a year after they accept their first patient. And then finally, this bullet is a little bit indented when it shouldn't be. The last category is sort of a catch-all. It's for extreme circumstances such as a natural disaster might have occurred that would have interrupted practice, unexpected closure of business, an EHR vendor that went out of business. Maybe you have a cloud-based EHR and that EHR vendor goes out of business and takes your information with it, or something catastrophic happens. There'll be a hardship exception for that. We haven't proposed this category, but we are soliciting comment on it. We have heard from several specialties that there are particular specialties, and the ones that we call out in the NPRM are radiology, anesthesiology, and pathology. And they face particular barriers that could constitute a significant hardship. We don't believe that any 3 of these alone are insurmountable, but together that may present some difficulties. So particularly for EPs that don't have direct interaction with their patients, that don't have a need for follow-up care or continuity of care with their patients, and who really for business or practice reasons don't have control over the implementation or availability of an ambulatory certified EHR. They may face some particular barriers in being able to meet meaningful use. We're asking for feedback on this. We're asking for feedback on whether there are other factors we should consider and whether there are other specialties we should consider. So please feel free to comment on that. As we sort of move to the Q&A portion of things, I will say a couple of things. One is that we do welcome feedback. Please comment. Please make sure that you comment on what you think works as well as what you think doesn't work. Often we hear from the vocal minority, and we don't always, they sort of tip the scales a little bit on things. So please make sure you tell us what you think works well. Also, as we move into the Q&A, because we're in a public comment period, I cannot always tell you the intention behind things. I really can't move beyond what's sort of in the NPRM. So if it's there, I will clarify it. If not, I may encourage you to comment on those type of things. So, Kate, I'm going to turn this over to you, and I'm going to move this back to Matt as a presenter.
Wonderful. Thank you so much, Rob. Fantastic, fantastic presentation, and I'm sure you'll be very surprised that we have lots of questions. So I'm just going to jump right in. We have, almost 20 minutes for questions. So, so first of all, Rob, if you attest meaningful use stage 1 in 2011, then you are expected to maintain stage 1 for 2012 and 2013 with no additional cash incentive until 2014 when we attest for stage 2 with a 1-year attestation period. Is that correct?
No, that's actually, it's a really great question, and it started to pop up. When you participate on the Medicare side, you participate in continuous years, and you get paid in continuous years. It just happens that your continuous years are going to be 3 at stage 1 and 2 at stage 2. So you will still get paid an incentive in every year. It's not based on the stage you're in. It's based on when you started and then, of course, on your Part B allowed charges.
Well, that sounds like good news. So we have another one, Rob. So if this is interesting. So if the Supreme Court rules to strike down the Affordable Care Act, how does that impact high-tech and the implementation of meaningful use?
We we started getting this question immediately after the hearing started up, and the short answer is that it doesn't. The EHR incentive programs were made possible by the HITECH Act, which is part of the American Recovery and Reinvestment Act. It is not part of the Affordable Care Act, and the Affordable Care Act is really what the Supreme Court is considering right now. So regardless of what judgment they release in June about the Affordable Care Act, it will not have an impact one way or the other on the EHR incentive programs.
Very good. So if the capability to exchange key clinical information is eliminated starting in 2013, does the need to possess the EHR software necessary to meet this objective, is that no longer required?
So in leading through 2013, so in 11, 12, or 13, the way that the certification is proposed is that you have to possess a complete certified EHR. And there's a broader definition of what possess means. You could have a licensing arrangement with a vendor where you don't actually have that piece implemented, but you do have to have access to it, essentially. However, beginning in 2014, we're moving away from that complete EHR concept, and you would move away from that. So in this case, right now, the way that certification is, you would need a complete EHR for everything that is required.
Do states have flexibility with CQM rulings in Stage 2 for Medicaid? For example, if the patient population does not meet certain threshold, CQM exemptions can apply. Is that right?
No, there isn't a difference fundamentally in how meaningful use and clinical quality measures work from reporting to Medicare or reporting to your state Medicaid agency. There is provided currently in Stage 1 the flexibility for states to implement some requirements for Stage 1 where they would essentially be able to move some of the public health objectives from menu to core. Currently, no state has enacted that, but we aren't changing it for stage 2. But as far as the flexibility that you're talking about, particular to clinical quality measures, that isn't one of the things that is proposed for CQMs in stage 2.
Is the eligible provider liable for a breach if a patient's computer is stolen or releases PHI, personal health information into unauthorized individuals or agencies?
You are beyond the purview of the Medicare and Medicaid EHR incentive programs on that. You're talking about HIPAA violations, and I would have to refer you to the Office of Civil Rights, which is the division within the Department of Health and Human Services that really oversees HIPAA and HIPAA violations.
Okay. How can we hold the provider responsible, if you will, for their patients accessing their information electronically?
It's a good question, and it's something that we discuss in the NPRM. I would encourage people to take a look at those sections where we discuss it. Again, one of the things that we said is that we believe that providers are, that we believe that patients taking part in their own health care is an important aspect of healthcare, and that we believe that providers are in a unique position to encourage patients to actually use those electronic resources. But again, we encourage comment on this.
Have the incentive dollar amounts available changed, and are the penalties for Medicaid and Medicare reimbursement applicable whether or not a hospital or physician accepts the incentive dollars?
So those are good questions. Let me first say that there has not been a change in the incentive amounts. The incentive amounts were set by Congress, and we didn't have any latitude in those total dollar amounts. I do want to clarify that when we talk about payment adjustments, they're really only applicable on the Medicare side. There are not payment adjustments on the Medicaid side. If you are eligible for both programs and you choose to participate in Medicaid instead of Medicare, which you well might because there are higher incentive amounts in Medicaid, you'll be deemed on the Medicare side, so you still won't get any kind of a payment adjustment. The payment adjustment, again, mandated by Congress, is that you have to participate as a meaningful user, and if you choose not to participate as a meaningful user, you'll be subject to that payment adjustment. So it is regardless of whether you choose to take advantage of the incentive payment.
So if a hospital attested for meaningful use stage 1 in 2011, can you describe specifically what the hospital was required to do in relationship to meaningful use?
For stage 1 in 2011?
Mm-hmm. I think that's what the question is, yeah.
I might do better to refer you back to our website to take a look at what was doing there. I know we're probably have a lot of questions specifically about the Stage 2 NPRM, but if they were participating as part of the Medicare EHR incentive program, then they would have had to have attested to 90 days of meaningful use and met all of the associated Stage 1 objectives and reported on those clinical quality measures, and then attested to that to receive an incentive payment. On the Medicaid side, they might have gotten a payment for simply adopting.
And I think this may be a follow-up to that one. So we as a hospital attested successfully to meaningful use in 2011. What do we submit for fiscal year 2012? 12 months of data using 2011 criteria? Is it to be submitted after October? Do we get another check in 2012, 2013?
Okay. So yes, your 2012, your entire fiscal year of 2012 will be your EHR reporting period. You're going to do 365 days of meaningful use at the Stage 1 criteria. You will attest, you have until 60 days, or I'm sorry, 2 months after the end of the fiscal year as a hospital to actually submit your attestation. So in other words, you'll do your year of meaningful use, and then sometime within 2 months of the end of the fiscal year, you'll go back to the website and you will attest for 2012 and give us the data on that. And then, assuming that you meet all of those thresholds, then you will receive an incentive payment for 2012.
For patient portals, is the assumption that the hospital and providers provide all patients with an account to access the information regardless of whether the patient requests that access or activation?
The particular measure for this one is that online access to health information is available for more than 50% of unique patients. So it isn't an all patients. The proposal is for 50%.
All right. So how does CMS propose that one eligible provider knows which EHR another eligible provider is on? We think this might impact the referral patterns.
That's a good question. There is some discussion of that in ONC's certification rule. We do solicit some comment about that. I can't, again, because we're in the comment period, I can't really talk about what our thoughts are about it or our intentions beyond what's in that section. But this is definitely a big step up and is really sort of the heart of the idea of information exchange, which we think is crucial to improving patient care with EHR. So I encourage everybody to look specifically at that objective. And again, this is the providing a summary of care after transitions of care objective. Because there are a number of places where we're soliciting comments on transport method and on the different measures that we employ.
This is sort of a comment and a question. So medication errors are very serious. Why is the threshold only 10% and not more at this time?
On medication errors, it's for the EMAR, the medication administration tracking. I think we have a little bit of a discussion about this in the NPRM, the theory being that the HIT Policy Committee, which is the federal advisory committee that proposes a lot of these objectives to us and which we use to sort of a framework for meaningful use for a lot of this, actually proposed a small number, to have it implemented within a particular area. We wanted to provide flexibility, and we talk about allowing the flexibility for a hospital to implement that in whatever way that they think is going to work at this point with their workflow.
Menu items 4 and 5 for an eligible provider, cancer and specialty database reporting, can both be met through cancer registry submission only, or is there something else that needs to happen?
I haven't, there isn't a particular discussion about this in the NPRM, and I couldn't tell you specifically about these objectives, but I will tell you that it has been a principle in stage 1. We were specific about it, and we even called it out in an FAQ where we talk about the implementing drug, and drug allergy checks not being able to meet the objective for clinical decision support. If they are separate objectives, they have separate measures and have to be met separately. So at this point, we aren't proposing in the Stage 2 NPRM any changes to those principles.
Rob, do you know how many providers nationally are currently reporting on PQRS and meaningful use Stage 1?
You know, I don't. Off the top of my head, that's sort of a different area from where I am. I can tell you that you don't, under the proposal that they're making here, you wouldn't have to just be reporting for PQRS and EHR incentive programs. If you were just an EHR incentive program participant, you could simply use that as a way to electronically report your clinical quality measures. It's sort of the infrastructure that we already have available, and rather than using the taxpayers' money to build a brand new system, we're proposing using a system that we already have in place.
So there's a question about your slide 21. I don't know, Matt, if you can get that back up. So on slide 21 about CQMs, did you say if eligible providers report on PQRS, it will count negatively against meaningful use attestation?
No, they would be deemed, and the entire point here is to get to the point where providers are not having to report multiple times on different measures to CMS. So essentially, if you are already reporting through PQRS, then you will have been deemed to also have reported for EHR incentive program, and that will that you'll have met that portion of meaningful use. The same is true for folks that are participating as part of a accountable care organization and reporting clinical quality measures. That way, you will be deemed to have already sent in CQMs for EHR. So essentially, you won't have to do it in two different places.
I don't know if you can answer this one, but I'll ask anyway. So has there been any progress at ONC in the adoption of a standard electronic master patient index for EMR vendors and that HIEs can implement?
I'm afraid that I work for CMS. I don't work for ONC, so I couldn't tell you what's happening with that agency. You could certainly send them, they do have a support email box that you could send a message to and ask them that question.
Fair enough. Okay, so for core item number 15, sending a summary of care information, how would or should the provider know, I guess we had this before, how would the provider know what EHR vendor is being sent to?
Right, and like I said, there is a discussion, a brief discussion of this in ONC's standards and certification rule, and we do talk about several aspects of meeting these measures in our own NPRM. I would encourage people to take a look at that and comment.
So there's a comment. I don't see any note of the 36-hour mandatory turnaround time to make all inpatient medical records available to a patient upon their request. Is the 36-hour mandate still present in Stage 2, or has it been removed or collapsed into something else?
It actually was always part of the e-copy of health information, and both e-copy of health information and the online have been collapsed into, it was number 10 on this slide, providing online access to health information. We are moving, obviously, to an idea of faster turnaround for providing these electronically, as you can see from number 11, where we move from the 3 business days to providing an office visit summary in 24 hours.
Are there any specific ways that specialists, not including radiologists, pathologists, or anesthesiologists, are affected differently in Stage 2 than other providers?
I think the structure you'll find is remarkably the same. It is the core menu structure. We still include a number of exclusions for the different core and menu objectives, and those are specifically to account for the differences in workflow between providers. So there is not a specialty track, just as there wasn't a specialty track in Stage 1, but there are exclusions for objectives that if you find that you don't practice a particular thing as part of your workflow and you meet that particular exclusion, you could be excluded from having to report on it and still be able to meet meaningful use. There are some places where we've actually provided a little bit more specifically for specialists, and one of them is the example of the additions for public health reporting for EP menu objectives, where you have ongoing transmission of cancer case information, ongoing transmission of data to a specialized registry. And then, of course, if you look in the clinical quality measures section and you look at the clinical quality measures that have been proposed, you'll see that there's some addition of some new quality measures for particular specialties.
So there's a little confusion about the fiscal year versus calendar year for reporting. So if an eligible provider does their 90-day period of reporting from January to March of 2012, does that mean they don't report their 12-month period until January through December of 2013? And does that mean there's a 9-month period in between where they can slide on the criteria?
So if you are in your first year of meaningful use, you have to report on a 90-day period within the calendar year if you're an eligible professional, if you're a hospital within the fiscal year. So a 90-day period within the year. As soon as you are finished with that 90-day period, you can attest and we'll begin the payment process with you. You are not required the rest of that year, so if you did January through March and then you attested on April 1st, you are not required to meet any of the thresholds from April through December. But the following year, beginning in January 1, you are going to have a full year of meeting those thresholds. So if you didn't attest in 2011 and you attested or you and 2012 is going to be the first year of participation for you as a meaningful user, then yes, you're going to do 90 days this year or October 1 if you're a hospital. If you already did your 90 days and you attested to it and received a payment for stage 1 in 2011, then 2012, your meaningful use period has already started. It started January 1st of this year. It'll go through December 31st of this year. And then beginning January 1st of 2013 and going until February 28th of 2013, that's your period to actually go back and attest to that full year of meaningful use.
So last question, Rob. So what do you do if you're in a community, or providers in a community where pretty much everyone is using the same EHR vendor? How are they going to meet the requirement to send to somebody using a different EHR?
You know, we call this particular example out and ask for comment about it in the NPRM. We talk about a concern of a high concentration of a particular vendor's software within particular communities, and we seek feedback from the public about how that could affect them for meeting meaningful use. So, so this is one of those areas where I have to say, please comment.
Very good. Well, thank you so much, Rob. We're going to have to let that be the last word. We're out of time, so we need to bring the program to a close. Thank you so much for a great presentation, great Q&A, and thank you all for joining us for the program today. We are going to pop a quick survey up on the screen, so please take a moment and fill that out. And also, please do plan to join us on April 11th for the first case study program of the Beacon communities of Western New York and Southeast Michigan. So thank you again, everyone, and have a great day.